Hello. This video introduces 360-degree patient safety appraisal, an evidence-based approach to help you get the full picture about patient safety in your practice, to stop misusing information about patient safety, and to prioritise rationally the kind of things you choose to spend time improving. We care very much about patient safety. In fact, centuries ago, the Hippocratic Oath established the principle that safety comes first as a core one for healthcare. In fact, it underpins our whole understanding of what good looks like. First, do no harm is a maxim that we've carried with us to this very day. And in recent years, we've seen a resurgence of interest in patient safety, particularly to take a more systematic approach to detecting, understanding and improving patient safety. And we've seen some very high profile and successful campaigns over the last few years in the NHS as well as internationally, which have engaged staff in hospitals in doing that much more systematic approach. But in general practice, we too care very much about patient safety, and right from the front of the organisation, from reception through our consultations to back office and our admin systems, we'd like to assure ourselves and our patients that we are doing all we can to detect, understand and improve the threats to patient safety which may exist. And it's that first step, the detection, which we're going to look at now. Because if we're going to be working on things to improve patient safety, it would be nice to assure ourselves that we had everything on the radar. If this was our radar screen, or sort of the total population of threats to patient safety, we'd like to be fairly confident that we've got the full picture, that that includes all of the things which are going on, so that we're not missing anything out, and so that we can have a rational and evidence-based conversation about the things we'd like to put some time and effort into improving. Unfortunately, the evidence and our experience shows very consistently there are some huge problems at the moment with our approach to getting information about patient safety. And there are a number of aspects worth listing about those problems. The first is that we have only a limited amount of information about the things going wrong in our care. I'd like you to think about how many patients, how many consultations a week are had in your practice, and then multiply that up to a whole year. How many consultations do you have? Thousands? Tens of thousands, hundreds of thousands, millions. We are incredibly busy in general practice. In fact, the work we do, the contacts, we have about 75% of all the patient contacts each day in the health service. We're very busy. Now look back and think how many significant event reports you have in an average week or an average year. What percentage of consultations is that? Most practices find it's a tiny percentage of consultations. The evidence repeatedly shows that we are picking up only a handful of the things that go wrong, or the near misses, or the safety concerns which arise. We have only a small amount of the available information on which to base our decisions about what to improve. The second problem is that those sources of information we use at the moment give us a limited range of issues. They don't cover the full spectrum of the things that are going wrong, and the evidence shows that time and time again. It's a real problem. Thirdly, we tend to take a reactive rather than a proactive approach to finding out about patient safety problems. Put crudely, we wait for something to go wrong and then we talk about it. We're also quite passive in our approach to the information we get about patient safety. It comes to us, we think about it. We're not very active or even proactive about seeking information about patient safety. And lastly, we tend to take a knee-jerk approach to choosing priorities for what we improve, which is a real problem because our time is finite. Choosing to put time into improving a particular patient safety issue is usually a major commitment of resources in our practice. And yet at the moment, we often take quite an ad hoc and knee-jerk approach to that prioritisation process. So some significant problems that we ought to find solutions to. Let's go round the circle and think about the current sources of information we have available to us, what their strengths and some of their weaknesses are, and then think about how we could fill in some of the gaps and take a much more holistic view which encompasses all of these different sources of information put together rationally. Broadly speaking, there are 4 types of information we could use to understand, to detect patient safety issues and incidents. There's our staff, external staff, patients and carers, and metrics or measurement. Let's look first at that first block, staff. And this is where, for most of us, the majority of our detection of patient safety comes from. And it's in the area of staff event reporting, or we call it significant event reporting in general practice. This is a really useful source of information. We're well used to it and it is readily available. All good things. But there are some features of staff event reporting that make it problematic. There are some aspects of it which mean that quite consistently it gives us only a small amount of information. So look at your ratio of significant event reports to actual consultations. And secondly, it gives us a narrow perspective. It gives us just a slice of the full range of spectrum of things that are actually going on. Let's unpick that one a little bit. So we know fairly consistently from research around the world that at best, staff event reporting picks up about 20% of the significant errors or adverse events which occur in care. That's probably the best estimate. In real life, it's probably way less than 10% in most of our practices. The second point I made was that it gives us only some of the issues. It tells us about only some of the issues. And we can illustrate this just by pausing for a moment to think about the kind of issues which have come up for you recently in significant event reports. For most of us, I think it's fair to say that the kind of things we get featured in our significant event reports are dramatic. They're the car crashes of life, the noteworthy, oh my giddy aunt kind of occurrences tend to predominate, in spite of the fact that actually they are only a small percentage of what actually happens in clinical practice or in our admin systems. They're also only a small proportion of the things that go wrong. There's another, much more frequent, but frequently overlooked kind of incident that I think is neatly illustrated by the opening of the book Winnie the Pooh. The book begins like this: here is Edward Bear coming downstairs now, bump, bump, bump on the back of his head behind Christopher Robin. It is, as far as he knows, the only way there is of coming downstairs, but sometimes he feels that there is another way. If only he could stop bumping for a moment and think of it. Speak to anyone in general practice and that experience of bump, bump, bump on the back of the head seems to be a really universal one. Our experience is that throughout the working day, small, undramatic, unremarkable things go wrong. They don't always reach the headlines. They don't always result in a car crash. They don't often result in a significant event report. But they're happening all the time. And they're important because many of them do actually make it harder for us to be safe. Many of them do actually result through a chain of events in real patient harm. But each individual occurrence seems so much part of everyday life, we tend to overlook it. It becomes part of the furniture. And so staff event reporting doesn't tend to pick up on it. So it gives us a small amount of data about a restricted set of things that occurs. It's not that those sets of things are untrue. The things that staff tell us in significant event reports are real and we should be thinking about them, but they are only a small part. They're just a chink of insight, and it's a chink of insight about a restricted set of the things that are actually going on. So should we give up on staff? No, absolutely not. Staff event reporting is really good and we should make it better. If you're interested in that, see our video about improving reporting in significant event audit. But actually there are things we can do to tap into staff's observation and insights and wisdom, which are really worthwhile putting in place alongside staff event reporting. And they involve going down this list a bit more. These are more proactive methods by which we can find out about patient safety. And things like surveys, so the Manchester Patient Safety Framework survey, or staff walk-rounds or briefings, or if you're really looking in detail at something, observation, are a more proactive way of going to the staff and saying, let's take 5 minutes, tell me something about how safe we are. Tell me about the things you go home worrying about, or would you have a loved one treated here? If not, why not? Why do you hesitate? Those sort of things that you can do really quickly and easily in something like a patient safety walk round turn out to do two really helpful things immediately, and then some other things in a less immediate term, sort of in the medium term. The first thing they do immediately is they give you a greater amount of information. If we are struggling at the moment to kind of make big priority decisions on the basis of a handful of bits of information, a walk round done every month or every 2 months will add to that information, so you've got a wider range of issues you can choose from. The second thing is that when you do walk rounds or surveys or briefings, what you find being picked up, what you find staff talking about, is a whole new set of problems, a whole new set of threats to patient safety, which very rarely make it onto a significant event form. You're getting a more complete picture. You're filling up more of the circle, and that's a good thing, because that means you've got a more accurate picture, you're not kidding yourself anymore, and also you can choose from a much better, much more informed perspective what things you want to improve. So that's staff, our own staff, and it's worth sort of going into a bit of detail on that. Let's think in a bit more pace about what we can use for other information sources like external staff. At the moment, strictly speaking, we don't routinely get much information from external staff, save for coroner's reports, which are a sort of mandated means by which we're meant to be able to detect safety issues and learn from them. I don't know about you, but in my conversations with practices around the country, I don't think many people really regard this as having been particularly impactful, coroner's reports, in terms of picking up stuff about patient safety. And so that sort of reinforces an insular approach to finding out about patient safety problems. We stick to ourselves and what we think within our own practice. But actually, there could be an awful lot of really useful information that we could get from people sort of outside our immediate team. Think for a moment, for example, about what would happen if you invited your community pharmacists to tell you about the top 3 threats to patient safety that they see in your practice. Or if you invited your district nurses along to the next significant event meeting and asked them to describe the number of times or the types of issues over which they have to sort of rescue the patient from something that nearly went wrong, or they get to hear from relatives or families about things that have gone wrong or nearly gone wrong. People who've tried this find 2 things. The first is they increase the volume of information they've got, and the second is they add new perspectives to those which their own staff are able to give them. They broaden the spectrum of the types of issues. They're much more, obviously if you speak to pharmacists, much more about prescribing safety and the prescribing system and patients' understanding about how to take medicines. District nurses tell us a lot more about referral processes and communication, about admission and discharge safety, the coordination of care. Things which go wrong fairly frequently, which they're busy rescuing patients from, but which we in our own practices often don't see so don't fill in a significant event form, or we've got a bit used to them, so we don't fill in a form. So adding to the range of people involved will add to the range of issues which we get onto our radar. Simple thing you could try as well if you have students, nursing students, medical students, even admin trainees or work experience placements, can give a really useful fresh perspective on how things go, and particularly the areas of our practice where it's really hard to do the right thing. Let's think now about patients and carers. And here too, we're not doing nothing right now. We are using a well sort of tried and trusted source of information in the form of patient complaints. This too is a bit of a reactive kind of approach. We wait for something to go wrong and for a patient or their family to feel sufficiently aggrieved about it for them to fill in a complaint. So it's a very reactive kind of approach. We don't get many complaints, thankfully, so we don't get a large volume of information about it. And there's something about the process of making a complaint that does tend to bias or filter the information that we get. We also feel, for understandable reasons, twitchy about complaints, and so they're often sort of hived off in a corner with an electric fence around them, and we don't really regard them as an integral part of our day-to-day learning, but they could be, particularly if we broadened the perspective a bit and did what we've suggested we could do with the other sources of information here. If we move, for example, from just asking about complaints to asking about comments, it's really interesting what happens. I was speaking to someone from an American hospital system where in their hospital wards they had a complaints box on every wall in the ward and in the outpatient departments. And in an attempt to get more information from patients and relatives and to broaden the perspective of it, they simply changed the labels on the boxes from complaints box to comments box. And what they found was two things. The first was they tripled the volume of information. They got a lot more information about things that could be improved. And the second was they started broadening it from complaints about things which were sometimes really hard to improve to comments about things which were easier to improve and actually were much more like the day-to-day bump, bump, bump on the back of the head. So staff were reading these comments and going, oh yeah, I recognise that one. But these were not things that had featured previously in staff event reports. They'd not got onto the radar before because they weren't car crashes, they were just bump, 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 and people tend not to report the bump, bump, bump of everyday life. But patients notice them. And if you do surveys or engage patients and ask them specific questions or even general questions, tell us about the safety of your care, you find a few things. The first is the evidence shows consistently that patients and their carers and families do notice patient safety issues and incidents. They understand them slightly differently sometimes, so you have to be careful about how you ask and use less technical language, but they get it. And they do see things, and they do pick things up. And they pick things up, some of which we never see. So the things which occur only once the patient gets home, that we're never going to fill in an event report about because we never get to see them. Secondly, they see or prioritise slightly different things from that which particularly clinicians do. So although we know that safe care involves great communication, good coordination of care and good continuity of care, I don't know about you, but there aren't many practices I hear of who get a lot of safety issues being reported about those issues of communication or coordination or continuity. But if you ask patients or their families about patient safety, they will tell you in really great detail about the kind of lapses in those three things, communication and coordination of care and continuity, that had a potential or an actual harm for them. really helpful in terms of increasing the level of information we have, but also crucially adding some bits of the spectrum which are frequently completely missing from the radar at the moment. So we're beginning to see how we could use existing resources to get better information, more comprehensive information about what's actually going on. We could get a more comprehensive and accurate picture and to have it less biased. Let's think finally about metrics or measurement. In hospitals, a huge number of things are measured to do with patient safety. Things in terms of the speed of which certain things are done, the infection rates, the return to surgery rates, pressure ulcers, a huge range of things are systematically, objectively, proactively measured and performance managed. And if you're involved in commissioning, you'll know about the way in which those things have become quite an important part of how we measure, evaluate, contract for services at the moment. How about general practice? I think for most of us the experience is that we measure almost nothing, if anything, routinely to find out about patient safety. But there are things we could do, and listed here are just some of them. We could do a rapid structured case note audit using trigger tools to find out what actual harms are affecting patients. We could use sentinel events, or sometimes called never events, as a means of finding out other things, like an example would be it's probably never acceptable for an older person to be on a long-term anti-inflammatory without some stomach protection from a PPI. It's probably never acceptable for someone to be taking warfarin for more than, let's say, 8 weeks without having their INR measured. We could routinely measure this stuff. And what would happen if we did is a variety of benefits would accrue. The first is that we would add to the volume of information we had. They would pick up on things we're currently not picking up on. What happens when you look in patients' notes and undertake a trigger tool review using this sort of case note audit process is that a type of issue starts coming up to do with where systems have failed that is very rarely put on the radar by any other source of information. There's something else which metrics would help us to do, and that is to do with the objectivity of our perspective and the ability we have to either know how frequent a problem is, that would be helpful for prioritisation, or crucially to know whether our hard work has been worth the effort. Let's just reflect a little bit more about that. Let's think about one of the properties of staff event reporting, that the information source we use most at the moment. I'd like you to imagine that right now someone rushed into the room and bashed your thumb with a hammer really hard. As you rush outside the door in pain, maybe to go and get a bandage or some paracetamol, someone undertaking a survey about people's body awareness stops you and asks you to name at random the first part of the body that comes to mind. Well, clearly you're going to say thumb, thumb! Why? Well, it's pretty obvious really. It sticks out like a sore thumb. You've got this big, painful, throbbing thing preoccupying you right now. So the first thing that comes to mind, the thing your attention is on, is obviously your thumb. What about 24 hours time? Somebody comes and asks you the same question. Name the first part of the body that comes to mind. Well, hopefully your thumb is less sore now, but it might still be throbbing. So you might say thumb, but it could have helped, it could have improved, and you might name any other part of the body chosen at random. How about in a month? Someone stops you and asks you to name quickly at random the first part of the body that comes to mind. You might say thumb, but you're just as likely to say any other part of the body. We know this to be true, it's obvious. Psychologists call it the von Restorff effect, or you could call it sore thumb bias. If something is recent, dramatic, and painful, it is in the forefront of our minds, and it will stay in the forefront of our minds for a period of time, and then it'll fade away again. Why is that relevant? I mean, we know this is true, it's obvious, it's common sense. Well, it's relevant when you come to ask about how common a particular patient safety issue is and whether it's changing over time. If we look back at the 360-degree circle and think about the comparison between using staff and using metrics, there's a tendency, a temptation even, to regard our staff as being an objective source of information about patient safety. But they're not. None of us is objective. We're human beings. We are subjective. We're influenced by our experiences, so we're influenced by things that go wrong. If you have had an issue recently where somebody has been really badly harmed by not understanding how to use their insulin safely, then for some time to come, if you've been affected by that, if it was your patient, chances are you will be much more alert to problems relating to patients' understanding of how to use potentially dangerous medicines. You're much more likely to notice them and to fill in a form about them. You're much more likely to talk to colleagues about them. You know, don't want to upset you, but I just wanted to point this out. I've seen this and you should be more aware of it. We get sort of quite zealous for a while, and then it fades off. I had the opportunity a few years ago to speak to someone who was involved in some national work around anticoagulant safety and described a real puzzle they had that panicked them for a little bit. They had a national awareness campaign reminding people about the dangers of anticoagulant prescribing and requiring every PCT and every hospital in the country to respond, describing the things they were doing to try and improve anticoagulant safety. And this central team were watching the reports about safety issues to do with anticoagulant come into them. And they were really worried to see that within a matter of days of issuing this report, alerting people to the safety concerns, the rate went up. And they were scratching their heads trying to work out why, in spite of this alert about patient safety, it seemed as though the safety of warfarin was going down. It was getting more safe. And so they actually sent people around the country doing interviews saying, what's happened? What are you doing differently? For goodness sake, this is terrifying. They found no credible answer as to why things were going wrong more often. But thankfully, after a peak, a few weeks elapsed and then it came down again, back to the baseline. And they said, well, we can't explain why this thing has happened, but thank goodness this sudden spike of safety incidents has calmed down again. Was it really a spike in the true incidence of patient safety problems to do with warfarin? Probably not. It was probably just because people had been alerted to it. It was in the forefront of their mind, and so they reported it more. If you want to measure patient safety, measure it. But staff event reporting is not a metric. It's not objective. It doesn't stay the same over time. It shifts, it changes. Train people in safer digoxin prescribing, and for a while they'll notice digoxin safety much more prominently, and then it'll fade away again. It's natural, and yet we often don't take account of that in the way that we measure patient safety. So, lessons from all of this. What should we do differently? Well, what do you think? I think one of the first messages about this is that some of the information sources we rely very heavily on at the moment should be relied on less. These ones at the top that I've slightly greyed out, they are reactive. They give us a small amount of data about a limited perspective, and we should move down the circle to find out more about patient safety from a broader range of perspectives. The second point is that there is very little overlap between the issues or the incidents that any one of these information sources detects. So studies have shown that if you get people for a short period of time to do really intensive staff reporting and external staff reporting, and you ask patients and carers to report issues as well, and you use objective measures looking at the patient's case notes to find patient safety issues, only about 9 or 10% of the things that go wrong are picked up by all of those information sources. If you want to find out about the full range of things that are happening, you need to be using as many different sources of information as you can lay your hands on. The next take-home message, I think, is that we need to be really clear that there is a distinction here between information sources which are qualitative, the things above the line, which are really useful for gaining insight and for understanding patient safety. They do flag things up. And things below the line, which are quantitative, they measure. They are useful for asking either how frequent a problem is or whether the changes we made have been worthwhile. And that's crucial. I wonder, think back to the beginning of this presentation when I challenged us by saying we take a knee-jerk and an ad hoc approach to prioritising things to improve. For yourself, for your own practice, over the past year, of the things that you've done improvement work on to do with patient safety, how many of them happened after, as a team, you looked at the radar, got the big picture perspective and said, which are the most common or the most serious, or a blend of common and a blend of serious things that we want to improve? Most of us don't do that. We have a significant event meeting, we discuss things that have been a sore thumb for somebody, and we work on improving them, irrespective of whether they seem, or whether we've measured them to be frequent or not. The second problem is, if you look back a year to the significant event things that you worked on a year ago, how many of those have been an improvement? How many of those have reduced the occurrence of errors or slips and lapses or near misses or failures in the system? How would you know? Most of us don't measure anything to do with that. We're doing lots of work and we've no idea whether it's the right work. We've no idea whether it was worth the time and the effort. And that's shocking. That's a terrible shame. So we need to be using things both above and below the line. The last point is that, generally speaking, things outside this red dotted line focus on errors. Somebody should have done something they didn't, or they did something and they really shouldn't have. Those are important, but not all of them actually result in harm to the patient. Things inside the dotted red line tend to focus on adverse events, things which actually reached the patient, irrespective of whether you can find a specific error that anyone committed. Maybe this thing happened simply because there was a gap in the way our processes are designed. Well, actually, wouldn't you want to know about both? Wouldn't you want to be proactively ensuring that some of the things we sought to improve were in the realm of errors and some were in the realm of adverse events, whether or not they were an error? So as we look at this, I wonder what things you think you ought to be doing differently in terms of getting information and in terms of prioritising, looking around and deciding what to do. And lastly, I wonder what you think you could do to be more active and dynamic here. So if something occurs, a comment or a complaint comes from a patient or their relative, or the district nurses alert you to something that occurred, how about we then go to some other information sources and check it out and triangulate a bit and see what we think, gain more insight, understand whether it's a priority. We could, if something like that happens, speak to some other staff, speak to the receptionists and see if they've noticed it or could shed some light on it. We might want to measure it to see whether this is going to make it on to our list of priorities to improve for the next 6 months. Similarly, if something's occurring or seems to be an issue when our metrics, it's never good enough just to make a decision on the basis of the numbers. We've got to ask staff, we've got to ask patients, it looks like this is a problem. It looks like, 7% of the time or whatever, this is happening and we don't think it should be. Before we act, we've got to understand. We've got to move above this dotted red line. We've got to be dynamic and quiz these things. We don't have to be captives of our information. We can be active users of information. And that too would help us enormously with our prioritisation. And actually, it would really change our culture. It would give us a much more heightened sense of awareness about patient safety. It would become a bigger priority for us. More people would be involved in it. We'd be demonstrating that we're more proactive about things. It's a sad thing, I think, that we're so reactive about patient safety right now. And it would help us to establish a better learning organisation. So it is possible, by using these insights, to get a larger amount of information about a more comprehensive range of issues. It is possible for us to start at the beginning with how we detect safety, change that, and actually take a more proactive approach all the way through, by being more dynamic with our information sources and having a more rational approach to prioritisation. So I hope that's been challenging. I hope it's been helpful, and I hope now that you feel able to start planning what you're going to do to get a bigger amount of information about a bigger range of the things which occur, so that you can give greater assurance to your staff and your patients that you genuinely are doing what you can to detect, understand and improve patient safety.